Very good evening. Yeah, am I audible?
Yes.
Yeah, you're audible.
Yeah, thank you. So we are going to start the free presentation section. I welcome the judges. Can you show the next?
Good evening, madam. Hi.
Next slide, please.
Vidya.
Hey, good evening, ma'am. Good evening.
The judges for the session are Professor Bivu Kallani Das, Dr. Surya Dubey, and Professor Manikandan. Next slide, please. Professor Bivu Kallani Das needs no introduction. She was a former head of the Department of Anesthesia, Neuro ICU, and Pain Clinic in Bangalore Institute of Neurosciences and IPGMER Hospital in Kolkata. She has had various positions in various organizations. Dean of Indian Academy of Pain Medicine. She is a past president of ISNAC, ANI, ISSP, and ISA, and ICCM. Madam is a member of the editorial board of various journals, IJ, Neurology India, to name a few. She has delivered orations at various platforms like the ISNAC oration, Professor R.N. Chatterjee oration, Hansraj Nair oration, and ISA West Bengal orations. And she has been bestowed with many honors and awards, and has got many publications, including chapters in the book in her name. Next slide. Dr. Surya Dubey, with the experience of 12 years, is presently working as an additional professor in the Department of Neuroanesthesiology, AIIMS, New Delhi. Sir's area of interest being neurocritical care, neurotrauma, neurophysiologic monitoring. He was a SNAC resident research travel awards awardee at San Francisco, USA in the year 2013. No. Next slide. Yes. And he's got 102 articles published in various international and national peer-reviewed journals with 6 book chapters. Next slide, please. Professor S. Manikandan is a professor and aide of Division of Neuroanesthesia at Sri Chitra Tirunal Institute of Medical Sciences and Research. He is also the Associate Dean, Division of Neuroanesthesia and Neurocritical Care. His sir's area of expertise being neurocardiology, neuromonitoring, medical device development, patient safety, and neuroanesthesia education. He has got 72 peer-reviewed publications, 4 book chapters, and trained more than 25 DM neuroanesthesia residents. Next slide. So as has already been conveyed to the participants, this is a paper platform presentation. The duration of presentation will be 5 minutes and the question answer session will be 2 minutes. Next slide. So these are the candidates. We have got 11 candidates in this category. So this is the order in which their video will be played. So with the permission of the judges, I am starting this session. So if organizers, please start the first slide.
Good evening, everyone. I am Dr. Uzma Begum. I will be presenting on efficacy of intranasal dexmedetomidine as an adjuvant during transnasal transphenoidal pituitary tumor resection surgeries. Transnasal transphenoidal is the preferred technique for resection of majority of pituitary tumors. This approach is minimally invasive. However, it is associated with specific challenges. First, the nasal passage is highly vascular, so bleeding can hamper surgical field quality. So preoperative nasal preparation is done by locally acting vasoconstrictors like adrenaline with lignocaine or xylometazoline. This increases the operating space of nasal corridor, thereby creating an oligemic surgical field and facilitate atraumatic nasal speculum insertion. Unfortunately, inevitable systemic absorption of adrenaline induces pressure response like hypertension, dysrhythmia, and even myocardial ischemia. We know that patients with Cushing disease and acromegaly have increased sensitivity to catecholamines, so these pressure responses can be dangerous for them. Secondly, the surgical technique per se results in intense sympathetic stimulation and associated hemodynamic responses. These responses increase the surgical site bleeding and compromise the operating conditions. Often frequent prompt administration of large doses of anesthetic drugs or antihypertensive agents is required. Such risk factor contraindicate use of adrenaline in TNT patients with coronary artery disease or in patients with severe hypertension often making the operating conditions suboptimal. Intravenous dexmedetomidine has an established role in TNT's procedure. There is very limited evidence on use of intranasal dexmed in endoscopic sinus and endoscopic TNT's procedures. Adjunctive efficacy of intranasal dexmed can be attributed to both local and systemic actions. To the best of our knowledge, at present there is no literature available which explores the role of intranasal dexmed in macroscopic TNTs. So with this lacunae in literature, this study was conducted with the aim to evaluate intranasal dexmed as an adjunct in macroscopic TNT surgery. Primary objective was to evaluate adjuvant effect of intranasal dexmed on nasal mucosal decongestion. Secondly, we try to assess the systemic adjuvant effect on these parameters. This was prospective randomized double-blind placebo-controlled trial. All the patients of pituitary tumor scheduled to undergo elective macroscopic TNTs who were fit to these inclusion and exclusion criteria were considered for this trial. Total 20 patients selected for the study were divided into two groups of 10 each. Group D patients received dexmed-soaked nasal pack, and Group C patients received normal saline-soaked nasal pack. The patients were given a nasal pack after induction of anesthesia. Nasal packing was done by ribbon gauze soaked with a drug as assigned. Subsequently, nasal packing was done using standard decongestant lignocaine with ADR. Morphometric assessment was carried out before and after each nasal packing step. It is done under endoscope visualization. Two parameters were measured using pituitary curate. First is middle turbinate thickness. Second is space between middle turbinate and nasal septum, termed as minimal negotiable window. Altogether, 3 readings were taken before nasal packing, after nasal pack 1, and after nasal pack 2. Statistical analysis was done using SPSS software version 21.0. P-value of less than 0.05 was considered statistically significant. These are the pictures taken at the time of study. These are the different sizes of pituitary curates. This is the vernier caliper measuring the outer diameter of the pituitary curate. This is the endoscopic view of nasal cavity showing middle turbinate and space between middle turbinate and nasal septum. Again, these are few pictures from the study showing how the measurements were carried out. Management of hypertensive surge was done using esmolol. Frommer's criteria was used for qualitative assessment of surgical field. Results. Altogether, the data of 20 patients were analyzed. The demographic data of 2 groups were found to be comparable. Morphometric assessment. After nasal pack 1 and 2, it was observed that the reduction in the middle turbinate thickness was more in group D as compared to group C, and p-value was found significant. Effect on the minimal negotiable window. A similar response was seen. The minimal negotiable window in increase in group D as compared to group C. The p-value was found strongly significant. The effect in surgical field quality. Frommer's score were found to be better in group D as compared to group C, but the difference was not statistically significant. Hypertensive response. Proportions of patients with hypertensive surge during various surgical stages were lower in group D as compared to group C, but the difference was not statistically significant. However, requirement of esmolol to control these hypertensive surges were significantly lower in group D as compared to group C. For hemodynamics and other parameters, the 2 groups were found to be comparable. Now coming to the discussion, this is the first study to evaluate role of intranasal dexmed as local and systemic adjuvant during macroscopic TNT surgeries. This is the first study to evaluate the objective parameters in addition to the relatively subjective scales. We found that middle turbinate thickness decreased significantly and a significant increase in the minimal negotiable window in dexmed group as compared to control group. Frommer's scale score for surgical field visibility was better in dexmed group as compared to control group, albeit not statistically significant. Objective evaluation shows that there is an actual increase in the working corridor for the surgeon. The incidence of hypertensive surges and the esmolol requirement was significantly lower in dexmed group as compared to control group. Intranasal dexmed may not be an alternative to the standard adrenaline lignocaine nasal pack, but it has a definite place as an adjuvant during macroscopic TNT surgeries, with the added advantage of a more stable intraoperative hemodynamics. It is certainly a useful option in patients with coronary artery disease in whom adrenaline is usually avoided because of the concerns of myocardial ischemia and cardiac dysarrhythmias. Small sample size is the limitation of our study. contingency imposed by COVID pandemic, we had to limit ourselves at 20 patients. Now I can conclude by saying that adjunctive intranasal dexmedetomidine significantly improve the surgical field visibility and also reduce the rescue antihypertensive drug requirement in patients undergoing microscopic TNTS procedures. Intranasal dexmedetomidine does not seem to influence the intraoperative propofol requirements or the post-operative recovery characteristics of these patients. Thank you.
Thank you, Dr. Uzma.
Yes, yes, ma'am.
Can I request Dr. Manikandan and Dr. Surya?
Dr. Uzma, what was the hypothesis of the study? You have not mentioned that you told because of COVID.
Yes, so the hypothesis of my study was does the intranasal dexmedetomidine significantly reduces the anesthetic and antihypertensive drug requirements, and it can decrease intraoperative bleeding and improve the surgical field condition in macroscopic TNTs patients.
So, what are the problems of dexmedetomidine? How did you know that 2 microgram per ml dose? Was there any prior study was available for you to give as a nasal pack, or you arbitrarily took it? Because
No,
we have
sir,
also
there are
used
studies.
because you know that 2 microgram may be too less to produce any response, because it will take long time
Sir,
for it to observe.
yes, yes, sir. So there was a study by Chow et al. In their study, they used 2 max per kg intranasally by giving with atomizer, and they found that the intranasal pre-medication with atomized 2 max per kg dex and decrease the amount of blood loss from the surgical side and provides optimal surgical field conditions.
Yeah, but that is for atomizer. But what you have done, you have stoked the ribbon gauze, no?
Yes, sir. Yes, sir.
So for that you require a lot of drugs. Actually, the amount, no, how much amount which is entering the patient, we will not be able to calculate. We will not be very specific in that condition. Dr. Surya.
Yeah, Uzma, what is the duration
Yes.
between your nasal packing and your assessment? How
Sir,
much?
the nasal pack was kept for 15 minutes, and then the measurements were taken. And after that, second nasal pack with Lugnicin EDR was given, and that was also kept for 15 minutes.
But my observation is that hemodynamics is fine. The
Yes, sir.
hemodynamic response is. But if the surgical field is really improving with that amount of dexmedetomidine, can we say that dexmedetomidine is causing that much vasoconstriction that it is improving surgical field as compared to adrenaline? Kind of, is it that strong a vasoconstrictor to, like, I mean, the surgeons were blinded to about the drugs, or who assessed the whether knowing what drug you are using?
So no, sir, surgeon and the anesthetist both are blinded at the time of study intervention, and we can say that that the intranasal dexmedetomidine may not be an alternative to the standard ligno EDR pack, but it has a significant role in as an adjuvant in mucosal decongestion and providing a stable
specific group of patients where you cannot use adrenaline.
Yes,
you
sir,
mean to
yes,
say
sir.
that? Okay, fine.
Yes,
okay.
sir.
Thank you.
So we move to the next candidate now. Next candidate.
Versus propofol on the stimulus dose was. Hello everyone, I welcome you on behalf of the AIMS Bhubaneswar. My name is Dr. Jaydeep Sanghan, junior resident from the Department of Anesthesiology and Critical Care. I'm going to present thesis article titled Effect of Ketofol versus Propofol on the stimulus dose for seizure in drug-resistant schizophrenic patients undergoing electrocorticography therapy, randomized crossover control trial. Starting with the introduction, recent evidence show antipsychotic benefits of ECT in treatment-resistant schizophrenia. Ketamine has been studied in last decade in depressive patients or in heterogeneous populations, either alone or as a part of other IV agent for ECT, and has been shown to increase seizure duration and or efficacy. However, its evidence as induction agent for ECT for schizophrenic patients is lacking. Also, the effect of ketamine on stimulus dose needs to be studied yet, which might impact the efficacy of ECT, hemodynamic parameters, and cognition. So we hypothesize that a 1:1 mixture of ketamine and propofol will decrease the dose of stimulus current required to produce a seizure as compared to propofol in schizophrenic patients undergoing electroconvulsive therapy. Aims and objective. Our aim of the study is to evaluate the effect of ketofol versus propofol on stimulus dose delivered in patients undergoing electroconvulsive therapy. Primary objective is to compare the stimulus dose of touch delivered between ketofol and propofol. Secondary objectives are to compare motor seizure duration between ketofol and propofol, to evaluate the time to recovery, that is defined as ability to spontaneous breathe between ketofol and propofol, to evaluate the effects of ketofol and propofol on hemodynamic parameters, to assess the cognition in terms of Montreal Cognitive Assessment Score, that is MoCA score, at the end of 4 sessions of each drug treatment group. Psychiatric satisfaction score at the end of each session, that is from 1 to 5. 1 is very bad and 5 is excellent. Methodology. Our study is prospective, randomized, crossover, double-blinded in nature. IC approval has been obtained, and written and informed consent from patients or relatives also has been obtained. Inclusion criteria are ASA grade 1 and 2 patients undergoing electroconvulsive therapy for treatment-resistant schizophrenia, that is non-response to at least 2 trials of antipsychotic medications of adequate dose and duration, and patients aged 18 to 70 years and of either sex. Exclusion criteria are patients with non-allergy to study drugs, patients or relatives denial to consent, pregnant and lactating females, patients with uncontrolled hypertension, history of myocardial infarction, increase in peritoneal pressures, and patients with ASA grading 3 or more. Sample size calculation. As per previous study, considering a difference of 20 millicoulomb to be significant, type 1 error of 0.05 and power of 80%, a total of 196 sessions will be required for the study. Considering a dropout rate of 12%, a total of 224 ECT sessions will be required, with 112 sessions in each group. As per our institutional practice, a patient is given 7 to 8 sessions of ECT at a time. Therefore, we need to recruit 28 patients in the study. Randomization is done by computer-generated simple randomization, and it is carried out by sealed opaque envelope of allocation. Our study is double-blinded in nature. For that, outcome assessor and psychiatrists were blinded. This is the Consort Diagram. Total of 31 patients were assessed for eligibility, out of which 12 patients were excluded because of exclusion criteria, and 28 patients were randomized into ketofol and propofol group. Every patient have received primary drug treatment for the first 4 sessions and alternative treatment for the remaining sessions. 3 patients in the ketofol group and 4 patients in the propofol group has ended early ECT treatment. So in 108 ECT sessions, patients have received ketofol, and 109 ECT sessions, patients have received propofol. Methodology. Anesthesia technique. After checking for eligibility and written informed consent, NPO status was confirmed. All standard monitors were attached. IV glycopyrrolate 0.2 mg was administered as a pre-medication. Each patient received assigned study drug for induction for dose of ketofol, that is ketamine 0.5 mg per kg plus propofol 0.5 mg per kg in group 1 and propofol 1 mg per kg in group 2. The cuff on the one limb was then inflated, and succinylcholine in dose of 1 mg per kg was administered. ECT technique seizures were induced by Navicure ECT system, which was delivered by bidirectional square-wave stimulation pulses with bidirectional electrode placement. The current delivered to the patient were decided by the psychiatrist as per standard institutional practice. Statistical analysis. Parametric data like age, weight, baseline MoCA score, psychiatrist satisfaction score, duration of motor seizure, and time to recovery were analyzed by Sprint test, and non-parametric data like current delivery were analyzed by Mann-Whitney test. Demographic variables. Both of the group were similar in terms of age, weight, comorbid illnesses, gender, and baseline MoCA scores. Coming to the outcome variables, our primary outcome, that is current delivery, was less in the ketofol group compared to the propofol group, but was not statistically significant. Duration of motor seizure was also not statistically significant, though it was higher in the ketofol group. Time to recovery, Montreal Cognitive Assessment score difference, and psychiatrist satisfaction score were statistically significant between both the groups, and it was beneficial in the ketofol group. This is the box plot showing current delivery between the ketofol and propofol group. Here we can see that outliers are present in both the groups, ketofol and propofol, and outliers were higher in the propofol group compared to the ketofol group. The median of both the groups were similar. This is the line diagram showing the heart rate and mean arterial pressure at the different point of time from the ECT and between the ketofol and propofol group. Here we can see that heart rate and mean arterial pressure just after the induction with the ketofol was higher compared to the propofol, but immediately after the ECT, both were similar. So discussion, our study did not show any difference in ketofol versus propofol in stimulus dose for seizure. One of the possible explanations could be that we use sub-anesthetic doses of ketamine, that is 0.5 mg per kg, as compared to previous studies where they have used higher doses of ketamine, that is more than 0.5 mg per kg, or used as a sole anesthetic agent. Other predictors of seizure threshold, like use of concomitant pharmacotherapy and previous course of ECT, might affect the course of outcome parameters, but all of them couldn't be possible to be evaluated in this study. However, one of the other important findings were improvement in cognition score of the patient, that is in terms of MoCA score in the ketofol group. We are also planning to study the 6-month follow-up for remission rates in both the groups. Limitations of our study are single center, small sample size, EEG parameters were not seen. So conclusion, ketofol when compared to propofol as anesthetic induction agent for ECT does not produce the stimulus dose for seizures. However, the recovery profile and cognition was significantly better with ketofol and need to be further evaluated in other studies. These are my references. Thank you.
Dr. Jaydeep.
Yes, ma'am.
So the conclusion is you are preferring ketofol than propofol.
Yes, ma'am.
That's your conclusion.
Yes, ma'am.
Study is a very small study, and any change in the hemodynamics?
Ma'am, in comparison to previous studies were stated.
Yes.
Yes, ma'am. Previous studies were stating that while using ketofol, there will be a higher blood pressure and heart rate. But we found that heart rate and blood pressure were higher just after the induction, but immediately after ECT, it was same only in comparison to the propofol. So after ECT, it was no difference between both of the group.
And the cognitive function was okay in both the groups.
Cognition was improved in the ketofol group compared to the propofol group.
Okay, so that is the advantage.
Yes, ma'am.
Question from Professor Manikandan and Dr. Surya.
Dr. Jaydeep, how did you do the cognitive assessment? When did you do? Because it is very difficult to do a cognitive assessment in a schizophrenic patient.
Yes, ma'am. Yes, sir. Generally, in our setup, sir, in every alternate day, they are doing cognitive function by MMAC score or Montreal Cognitive Assessment score, sir. So by that one.
But means you did it not on the same day after the ECT. You did on the next day.
Yes, sir. Yes, sir. Next day.
So that will be fallacy, you know. The drug will act how much? It lacks only very short time.
But sir, according to the criteria, so just after ECT, there will be like a post-ictal phase. So after 6 hours only, we can do.
Yeah, I know that. That's what one of the fallacy of the study. What this cognitive, what you have done, may not impacted by this anesthetic regimen. That's what I am saying. Okay, thank you.
Yes,
Dr. Surya.
No questions. Thank you.
Yeah. Okay. Yeah.
Thank you, sir.
Yeah. Next candidate, please.
Hello everyone, I am Dr. Senthil Kumaran, resident in Department of Anesthesia, PGMH Chandigarh. My main guide is Dr. Nidhi Pandamam. My study is comparison of 0.9% saline and balanced salt solution on acid-base balance in patients undergoing intracranial aneurysm clipping, a randomized control trial. So fluid balance in patients with aneurysmal subarachnoid hemorrhage. Patients with SAH are hypovolemic in the preoperative period due to inadequate oral intake, decreased GCS, and use of osmotherapeutic agents, and also development of cerebral salt wasting syndrome. Hence, the perioperative fluid management in these patients is aimed to avoid dehydration, maintain an effective circulating blood volume, preserve cerebral perfusion pressure, and minimize cerebral edema. Cerebral edema can occur if there is an imbalance in fluid volume and osmolarity, which can rapidly become life-threatening. For neuronal homeostasis, cerebral perfusion and hemodynamic stability are essential. 0.9% saline versus balanced salt solution. 0.9% saline is also known as normal saline, but this is not physiologically normal because the concentration of chloride is higher than plasma. It also causes decreased renal cortical blood flow, delayed and decreased urine output, gastrointestinal dysfunction, and acute renal failure. Balanced salt solution could reduce the incidence of metabolic acidosis because the chloride concentration is reduced by the use of various other electrolytes while maintaining normal osmolarity. Plasmalite A is a balanced crystalloid, which almost resembles human plasma in its composition. As we can see in the next slide, 0.9% saline versus plasmalite A compositions Sodium and chloride are at concentration of 154 milliequivalents per liter in 0.9% saline, while plasmolite A has reduced chloride concentration, while it contains magnesium, acetate, gluconate, and has an osmolality of 294, almost equal to plasma, and also has a pH which is identical to plasma. So our study hypothesis that balanced salt solution will have a better acid-base profile compared to 0.9% saline when used in the perioperative period in patients undergoing clipping for rupture intracranial aneurysm. So our study aims to compare 0.9% saline and balanced salt solution in terms of effect on acid-base balance, secondary outcomes like serum lactate, anion gap, serum electrolytes, renal function test, biomarkers of acute kidney injury, intraoperative brain condition, and neurological status using modified Rankin scale. As is a prospective double-blind randomized control study conducted at Neurosurgery OT and Neurosurgery ICU at PGIMH Chandigarh between July 2020 to November 2021. Institutional Ethics Committee clearance was taken and trial was registered in CTRA prospectively. 60 patients, 30 patients in each group aged 18 to 75 years, belonging to ASA 1 and 2, scheduled for clipping for rupture intracranial aneurysm, having WFNS grade less than or equal to 2 were included in the study. Balanced anesthesia was administered to all patients. TIVA was used in the intraoperative period. Patients received 0.9% saline group NS or plasmolite A group BS, preoperatively based on focus of IVC, intraoperatively based on goal-directed fluid therapy with replacements for loss, and postoperatively for 48 hours. So coming to sample size calculation, assuming a level of significance of 5% and a power of 90% in order to detect a mean difference of 0.034 in PS between the two study groups with a standard deviation of 0.03, the sample size was calculated to be 27 in each group. Considering dropout of 10%, the sample size was calculated to be 30 patients in each group. This was the Consort diagram. The demographic profile between the two groups was comparable. Coming to the primary outcome, the pH at first hour between the two groups varied significantly, with NS having a lower pH. The bicarbonate values at second hour and 24 hours post-operatively varied between the two groups, with NS group having a lower bicarbonate values. The base deficit values were higher in NS group compared to BS group at second hour and 24 hour post-operatively, which was statistically significant. Coming to secondary outcomes, the anion gap and lactate between the two groups did not show statistical significance. The sodium, potassium, calcium electrolyte between the two groups did not vary much, while chloride at post-op 24 hours showed a significantly higher value in NS group compared to BS group. Coming to renal function test, blood urea between the two groups did not show any statistical significance, while creatinine at post-op 24 hours and 48 hours showed a significant difference between the two groups, but then they were within physiologically normal limits. Coming to biomarkers of AKI, the urine NGAL and serum cystatin C between the two groups failed to show any significant difference in the pre-op and the post-operative period. But then the intra-group comparison of the same in the pre-op and 48 hours post-op had a significant difference in the NS group and also in the PS group, while the serum cystatin C did not show any intra-group difference. The brain relaxation score showed no significant difference between the two groups. There was no significant difference in neurological outcome as assessed by modified Rankin scale at discharge 1 month and 3 months. In a study by Dey et al. In elective craniotomy in supratentorial tumors, they found that plasmolite A maintained a better acid-base profile. They found a significant difference in serum NGAL values between the two groups, which was not seen in our study. In the study by Young et al., 0.9% saline was compared with plasmolite A for resuscitation of trauma patients. They found that there was a significant improvement in base deficit in the plasmolite A group at 6 hours into the study, while in the 0.9% saline group, the base deficit was uncorrected even after 24 hours. In a study by Hassan et al., normal saline was compared with sterofen in traumatic brain injury patients. They found that 0.9% saline group had significantly lower bicarbonate values than the balanced fluid groups. These studies correlated with the findings in my study. The limitations of my study was the sample size. The study was statistically powered to find significant difference in pH, but was not adequately powered to find significant difference in other secondary outcomes like biomarkers of AKI, brain relaxation score, etc. Our study was done in a subgroup of neurological populations with a good grade aneurysm. Generalization to poor grade aneurysms and other neurosurgical populations may not be possible. Future studies can be aimed to overcome the above limitation with a larger sample size. So I conclude by saying that perioperative infusion of 0.9% saline exhibits tendency for shifting the pH towards acidosis. Balanced salt solution like plasmolite A may be superior to 0.9% saline for use in perioperative periods in patients undergoing clipping for rupture intracranial aneurysm. These were my references. I thank the SNAC team for giving me this opportunity.
Thank you, Dr. Senthil.
Yes, ma'am.
And
Good evening.
questions for Dr. Senthil, Dr. Manikandan, and Dr.
Senthil, what is the amount of volume you had given between these two groups? So what is the relationship of volume with respect to ABG as per the literature? Is it corresponding to your study or?
So the volume was determined in the preoperative period with focus of IVC, in the intraoperative period based on goal-directed fluid therapy. and post-operatively based on IVC assessments and as per the requirement assessed by the neurosurgeon. The volume between the two groups was volume given between the two groups was comparable statistically, sir. And as far as the literature is concerned, as respect with volume, I'm not sure, sir.
Now, how much normal saline you give to the pH will change when they will get the hypochloremic acidosis. What are the
yes, sir.
In your this one?
Yes, sir. Sir, more than 2 liters in a short span of time, because the crystalloids have a short TF inside the intravascular space. So only then they cause a significant metabolic acidosis.
In your study, you must not have given so much saline in within that 2 hours. Correct, no?
Yes, sir, true. Sir.
Also the limitation when you look into the long. And second thing, subarachnoid hemorrhage itself can cause renal injuries because it's a systemic inflammatory medium. So,
yes.
Okay, did you rule out that this only the fluid is responsible for this one? So, like.
Yes, sir. Urine NGAL is quite sensitive for detecting. Okay, sir. It will be a limitation, sir. It cannot be different.
Yeah. Okay. Otherwise, very good study. Okay. Yes. Yeah. Dr. Surya or Madam. Yeah.
Senthil, what was your goal-directed fluid therapy algorithm in intraoperative fluid management?
Yes, sir. Sir, we have a protocol of securing intra-arterial BP monitoring for all the patients, sir. So we have SPV values displayed on our monitors, sir. So more than 12 of percentage.
SPV based.
SPV based, yes.
Another fallacy is that if you are studying NGAL, better to have a serum NGAL only, because if you are looking at renal failure, what about an anuric patient then? You will not be able to assess the NGALs then. So it will be a sensible option if you're opting for a serum NGAL. And my suggestion is that if you would have included Akin or a KIDCO scoring for these patients for renal failure assessment, that would have been a better data. But anyway, it's a good study. These are my suggestions. You can plan it in another studies if you are planning.
Sure, sir. Thank you.
It has to be an objective assessment scale for renal failure as well.
Yes. Thank you.
Next candidate, please.
Good morning, everyone. Here I am presenting a paper. Topic is a comparative study to evaluate induction characteristic of thiopentrone sodium and intermediate during general anesthesia in patients undergoing surgery for traumatic brain injury. Coming to introduction, anesthetic agents that produce rapid onset of hypnosis and rapid control of the airway without an increase in ICP, providing hemodynamic stability, are preferred in patients undergoing surgery for traumatic brain injury. Sodium thiopentrone and intermediate are known drugs commonly used for induction of anesthesia. Both agents decrease the systemic hemodynamic response to intubation and blunt the increase in ICP and decrease the cerebral metabolic rate for oxygen. In the past, thiopentrone and intermediate have been compared together as well as individually with other drugs for elective surgeries under general anesthesia. However, there is a paucity of studies comparing the two drugs as induction agent in adult patients undergoing emergency surgery for traumatic brain injury. Therefore, we took this prospective randomized double-blind study to compare both these drugs with respect to hemodynamic parameters during the surgery. Coming to material and method, a total of 100 patients age of 18 to 55 years underwent emergency craniotomy for traumatic brain injury were selected for the study, and exclusion criteria were history of hypersensitivity to the drug, known primary or secondary adrenal insufficiency, or patient of steroid medication, and polytrauma patient with massive hemorrhage. The patients were randomly assigned in two groups. Both groups were 50-50 patients. Group T was given thiopentrone sodium 5 mg per kg, and group E was given intermediate 0.3 mg per kg. Baseline parameters, heart rate, mean arterial pressure, and SpO2 were recorded. Induction of anesthesia was achieved with intermediate 0.3 mg per kg or thiopentrone 5 mg per kg along with the fentanyl 2 mg per kg by a fellow anesthesiologist unaware of the study protocol as per the group assigned. Clinical assessment of the patient was done by loss of eyelash reflex, and end-tidal CO2 was monitored. IV rocuronium 0.9 mg per kg was given to facilitate the orotracheal intubation. After monitoring of the parameters, heart rate, mean BP, and SpO2 for 15 minutes, and surgery was commenced, and maintenance of the anesthesia was done with isoflurane in 50% of the nitrous oxide with fresh gas flow of 5 liter. Intraoperative hypertension, mean of less than 60 mmHg due to the induction agents, was managed by the use of IV ephedrine bolus of 3 mg. At the end of surgery, the residual neuromuscular block was reversed and patient was shifted to ward ICU. Patient was followed up after 6 hours, 24 hours, 48 hours, and 7 days. Coming to the statistical analysis, the statistical testing was conducted with the statistical package of social science system version of 17. The comparison of normal distributed continuous variable between the groups was performed using the student t-test, and nominal categorical data between the groups was compared using the chi-square test or Fisher extract test as appropriate. Intermediate and thiopentrone drug at 2 site type 1, error of 0.05, 90% power and standard deviation of 15, a sample size of 50 per group is required to detect a significant difference. Coming to observation and discussion, there was no significant difference between the groups for the hemodynamic and respiratory variables prior to thiopentrone and intermediate administration. Showing side effects with two drugs. One is the pain on injection site, and another one pain on injection, and another one is myoclonus. So when we compare two groups, group T and E, there was significant increase in pain on injection and myoclonus in the group E or intermediate group. Coming to the comparison of heart rate and mean BP. So in heart rate, there was significant decrease in the heart rate at the induction with the group E. And after that, there was a sharp rise at the time of intubation, and then decrease in and maintenance of the heart rate in group E comparison to the group T. Coming to the mean blood pressure, heart rate, mean blood pressure difference was in group E. Firstly, it showed decrease in the at the time of intubation, and then it rise of just 2 minutes after the intubation, and or at that we can say at the time of intubation, and then there was a decrease and subtle baseline was there with the group E. The two groups were similar demographically in terms of age, its gender, and weight. Like Karki and Ujiar et al. Did a comparative evaluation of the three thiopentrone, propofol, and intermediate in the patient of 18 to 50 year age. And Kim et al. Compared intermediate thiopentrone in patient undergoing cerebral aneurysm surgery with demographic profile of the patient similar to our study. Effect of thiopentrone was also found to be similar in our study as compared to Tarnow et al. Tarnow et al. Heavily premedicated their patients with meperidine 1 mg per kg, promethazine 0.5 to 1 mg per kg, and atropine 5 to 10 mics per kg IM 90 minutes before the induction of anesthesia, which might have led to such insignificant variation in the heart rate. So cardiovascular effects of anesthesia can also be influenced by the multiple drugs received by the coronary artery disease patients like antihypertensive, beta blocker, calcium channel blockers. Our study included patients of the head injury, many of whom might lack full optimal hemodynamic resuscitation. Also, the episode of hypotension and requirement of vasopressor was not required in the intermediate group. And pain on injection, myoclonus are important side effects associated with the intermediate, while thiopentrone causes phlebitis and venous irritation and pain on injection. Conclude, intermediate produce a more subtle and hemodynamic compared to thiopentrone, which is important in TBI patients. Pain on injection, myoclonus are no side effect of intermediate, which can be reduced by effective premedication use prior to induction of anesthesia.
So it's a good study, but what is the
Questions, please.
So you mentioned about the myoclonus following intermediate, and you have you also suggested that you have used any of the pre-medication. What pre-medication to prevent this you have used, and have you used in both the cases? Hello? Dr. Geeta?
Yes, ma'am. Yes, ma'am. Yes, ma'am. Ma'am, we did not give any specific pre-medication for that. Ma'am, there was one study in which Tarnow et al. Used pre-medication, like meperidine 1 mg per kg, promethazine 0.5 mg per kg, and atropine 5 to 10 mics per kg. But we did not use like that, ma'am. We used only glycopyrrolate and midazolam.
Midazolam you have used.
Yeah.
And how you blinded the study?
Ma'am, it was prospectively randomized double-blinded study, ma'am. Ma'am, the anesthesiologist which gave the drug, who gave the drug was blinded, ma'am. He did not know the drug which was used in that particular case.
Dr. Manikanda?
Yeah, Dr. Rita, what is the color of intermediate? What is the color of thiopentrone?
Sir, intermediate is of white color, white in color, whitish, and thiopentrone is in yellowish color, sir. Means it is in powder form when we used NS to make it. Yes,
So
sir.
how you blinded
Yeah,
that thing?
Blind is no, sir. Yeah, that's what the one of the major drawback of this study. Okay, so you
Yes.
cannot blind it.
Yes,
Anesthetists
sir.
will know what drug you are giving. No, okay, that is one of.
Yes, sir.
And the most of the things what you have mentioned is already existed in the literature. Stability, myoclonus, and all those available. Okay, Dr. Surya.
No question.
Next candidate, please.
Yeah, no question.
Good evening. My topic of presentation is evaluation of transcranial Doppler velocity variations and the assessment of cerebral oxygenation by near-infrared spectroscopy in patients undergoing neurosurgical procedures as a novel marker of clinical outcome. It is a prospective observational pilot study. So TCD has been used non-invasively to measure the cerebral blood flow, and the correlation has been made to vessel diameter, and as well as the indices has been used to measure severely raised ICP in traumatic brain injury and in brain dead patients. And serial measurements have been used to assess the autoregulation. So our hypothesis was that variation in transcranial Doppler velocity in the spectral pattern and optic nerve sheath diameter can be used to indirectly measure intracranial compliance and also to predict outcome. The primary objective was to correlate the different spectral patterns in the TCD in different GCS group patients and to correlate the spectral changes with the outcome of the patients. The secondary objective was to correlate TCD with NIRS and also to correlate this with GCS scores, optic nerve sheath diameter, and NIRS values in the pre-operative to post-operative 24 hours and at the time of discharge. The justification of the study was that TCD spectrum in the form of variation in the systolic velocity as well as pulse velocity variation along with the indices and the correlation to the raised ICP features like GCS and optic nerve sheath diameter has not been previously done. After ethics committee approval, patients were divided into two groups of GCS 14 to 15 and GCS 9 to 13 after satisfying inclusion and exclusion criteria. The preoperative TCD, NIRS, and ONSG values were done, and standard anesthesia induction was done. And postoperatively, the values were repeated at 24 hours and at the time of discharge. The clinical correlation with the condition of the patient, imaging parameters, and the surgery performed, along with the GCS at the time of discharge, as well as the outcome scale at hospital discharge was done. The transcranial Doppler indices that we measured were identifying the wave in the TCD spectrogram with the maximum velocity, and the peak of that wave was labeled systolic velocity maximum, and the trough was labeled as diastolic velocity maximum. And in the same reading, the minimum systolic and diastolic velocity waves were also identified. And pulse velocity variation was measured by pulse velocity maximum minus pulse velocity minimum by pulse velocity mean into 100. So this was the DCD spectrum of one of our patients, and the waveform with the maximum height was identified, and the systolic velocity maximum and diastolic velocity maximum was taken. And the waveform with the smaller height in the spectrum with the systolic velocity minimum and diastolic velocity minimum was measured. And the values were measured within the machine itself. And statistical analysis was done with mean plus standard deviation, and unpaired t-test was done to analyze parametric data. And repeated measures of ANOVA was done to measure the serial changes in the values. And in the demographic, more male patients were there than the female patients. And the changes in the map were high in the low GCS group with a higher MAP in them, and this was statistically significant. And the mean GCS in the low GCS group was 11. And comparing the TCD parameters, the pulsatility index, resistivity index, and the systolic to diastolic ratio was higher in the low GCS group, and this was statistically significant. In comparison of the NARS values within the group right and the left side, and the same group in the preoperative to postoperative period, as well as between the groups, there was no statistical significance. Comparing the ONSD values, the preoperative ONSD values between the groups were significant in both the sides, and the mean values were also statistically significant, comparing between group from the preoperative to the postoperative side, and as well as between groups from both sides. And this was the first study that shows that ONSD values are higher in the patients with lower GCS. And comparing to the pulse velocity variation, there was a increased pulse velocity variation in the preoperative period, and this decreased towards the postoperative period. And this was statistically significant. And this was seen in the poor GCS group patients also. And comparing the systolic velocity variation, even though there was a higher value in the preoperative period, the values decreased in the postoperative period, but this change in both the groups were not statistically significant. So pulsatility index has been correlated with poor outcome because it was indirectly correlated with raised ICP. So we suggest that pulse velocity variation is a novel method to identify the impairment in intracranial compliance. And patients with reduced GCS with poorer intracranial compliance had a higher PPV value in the preoperative period, and these values improved in the postoperative period. And this was correlated with the ONSD values being higher in the preoperative period, which decreased in the postoperative, suggesting that the intracranial compliance improved. But we could not make a correlation between TCD spectral changes and NIRS, and as well as the outcome of the patient. And the limitations of the study is that it is an observational study, wide group of neurosurgical patients, there was no concomitant ICP measurement, and it was not correlated with MAP, and the sample size was low. In conclusion, pulse velocity variations can be used as a novel marker for surrogatively measuring the intracranial compliance, and serial studies help us to understand which part of the compliance curve the patient falls into, and this allowed to titrate the interventions to control the raised ICP prior to the appearance of clinical changes and thereby improve the outcome. Thank you.
Questions, please.
Thank you, Jeeva. That nice presentation. It's a very good study you have done. And one thing I can ask you, what are the exclusion criteria? You have, for example, a retroorbital tumor or like this. Have you excluded them? Hello? Hello, Dr. Jeeva? It's not there. Dr. Surya?
I'm not able to see the candidate actually.
Yeah, that's the thing. Hello? Dr. Jeeva, is he there? It's not there.
I'm not seeing her in the chat box in this one participant.
Yeah, she probably hasn't joined. Okay, we have to move on to the next person.
Yeah,
Next. The questions for her afterwards then.
Yeah, if she joins. Next candidate, please.
Good afternoon all. Myself Dr. Sakshi from AIMS Rishikesh, DM Neuroanesthesia and Critical Care. So my topic for pre-paper presentation is role of allogenic blood transfusion in development of post-operative infection in neurosurgical patients undergoing intracranial surgery, a retrospective study. Blood transfusions are often required in complex neurosurgical procedures, and patients often end up receiving allogenic blood transfusion, especially in developing country like ours, due to lack of facilities available for autologous transfusion. Various studies have been conducted to analyze the relationship between allogenic blood transfusion and post-operative infection, but similar study in neurosurgical patients are lacking. So our study aims at filling the above lacuna. So our aim was to study the relationship between blood transfusion and occurrence of post-operative infection in neurosurgical patients undergoing intracranial surgery for tumors and aneurysms. The objectives were to establish the relationship between blood transfusion and post-operative infection, to calculate the percentage of neurosurgical patients requiring perioperative blood transfusion, to calculate percentage of various types of post-operative infection occurring in neurosurgical patients. Data were analyzed retrospectively from medical records for all the intracranial surgeries performed during the period of 3 years, that is from 2017 January to December 2020, and the collected data was tabulated in MS Excel and analyzed with SPSS version 20.0. Perioperative blood transfusion was defined when blood was transfused 7 days before and up to 30 days postoperatively. Postoperative infection was defined as development of any infection within 90 days of surgery. Patients included were those who were having intracranial tumors and aneurysms and were into category of ASA 1 to 3. Patients who are in ASA 4 or higher coming from other surgeries, and patients who are having preoperative anemia, pregnant females, and patients with pre-existing infections were excluded. Categorical variables were reported as absolute numbers and percentages. Quantitative variables were reported as mean and given along with their standard deviation. To detect significant difference among groups, the chi-square test was used for categorical variables. Statistical significance was established at alpha power of 0.05 and all reported p-values are two-tailed. So patient characteristics are shown. A total of 260 patients were included in our study. The mean age of the patients were 40.78 years with standard deviation of 17.59. The BMI of the patients were 20.33 kilogram per meter square with a standard deviation of 5.01. 55% of the patients were male. 80.8% of the patients did not have any comorbidity, whereas 11.5% of the patients were hypertensive. 23.5% of the patients were smokers. About 15.4% of the patient had post-operative infection, and 4.2% of the patient had urinary tract infection. 2.7% of the patient had bloodstream infection, and 2.7% of the patient had respiratory tract infection. Chi-square test was applied to study the association between post-operative infection and peri-op transfusion. Out of 260 patients, 39 patients had post-operative infection, whereas 109% had peri-operative blood transfusion. And when chi-square test was applied, the p-value came out to be 0.001, which was considered to be very significant. The neurosurgical procedures are usually associated with significant amount of blood loss. Secondary brain injury, which has shown to occur at a hematocrit of 20% or less, but with impaired cerebrovascular reserve, as in most of the neurosurgical patients, tissue hypoxia and cell injury may occur even at higher hemoglobin levels. Children undergoing neurosurgery have a higher transfusion likelihood as compared to adults. Transfusion hazards like TRALI, TACO, and transfusion-related immunomodulation, septicemia, although they are not specific to neurosurgical patients, but are a warning sign when ordering blood product transfusion. In a retrospective cohort study by Fizan et al. On 56 patients undergoing spine surgery, overall infection rate was greater in patients who underwent transfusion than those who did not. In 2014, Friedman et al. Conducted a post-hoc analysis of the pooled record data stratified patients in elective total hip arthroplasty or total knee arthroplasty and observed that rate of any infection was 9.9% in patients who received allogenic blood transfusion and 7.9% in patients not receiving allogenic blood transfusion with or without autologous blood transfusion. So we in our study also had findings consistent with these studies. We had quite large number of the patient, 260 patients, which was a major strength of the study, but there were few limitations also. Being retrospective in nature, we have to rely on information in medical records only. Thus further prospective studies are needed. It was a single institute study, so we need further multicentric study. Also, it was just an observational study, so further cohort studies should be done to confirm the findings. So to conclude, perioperative blood transfusion has been found to be associated with increased risk of post-operative infections. Thus, it is important to have risk-benefit ratio before transfusion of blood and blood products. Thank you.
Questions, please.
And there are many factors which is responsible for post-operative infection.
Yes, ma'am.
And how can you say that this is only the blood transfusion you can point out towards this?
Yes, ma'am. We cannot say for sure that the post-operative infections that has occurred in these patients is due to blood transfusion alone. But actually, ma'am, we need to have the cohort studies to rule out the other factors, other confounding factors, which we need to rule out whether it was due to blood transfusion or due to the other factors. Oh, and further, because of neurosurgical patients, they stay in the ICU for quite a long period of time. So it can be hospital acquired also. So we cannot rule out that certainly.
So pre-operative, you have excluded all there is no infection before.
Yes, yes, ma'am.
By what? What are the parameters you have seen?
We have that comes in our exclusion criteria. If a patient is any from the culture studies, if the patient is having any positive culture, so we rule out that patient. And if the patient is having any fever or the tachycardia or tachypnea, if we suspect that patient is having any signs of infection, we have ruled out. We have excluded those patients from our study.
So pre-operatively, the patient has come to the ICU.
No, sir. We retrospectively
So
only we have an.
You have taken that this patient has no infection anywhere.
Yes, ma'am. From the data only we have taken that, ma'am, because it was a retrospective study. We have not done a prospective study, and it was not blinded also. So like it was just based on the medical records.
So it's a retrospective study. So this is very much limited.
Yes, ma'am. Yes, ma'am.
Dr. Surya.
Yeah, not many things madam has pointed out. What is your transfusion criteria? What on what basis you decide transfusion in those patients, and what are the patient characteristics? Was there mainly brain tumor patients or spine patients also included?
The intracranial surgeries, either tumors or aneurysm, both we have included. Supratentorial, infratentorial, as well as aneurysms of any of the arteries.
My suggestion is that if you have focused on a particular group of patients, then it would have been a better data, because it is a heterogeneous data. Then you just cannot compare a big aneurysms, a big intracranial tumor surgery and its post-operative outcomes with a smaller aneurysm surgeries. If you have stratified it, that would have been a more meaningful data, I presume.
Yes.
But anyway,
Dr.
Thank you.
No question, madam. Both are. I agree with both of your comments.
Dr. Jeeva has joined, so judges, you can ask your questions.
We'll ask her. Okay. Dr. Surya.
Yeah.
Please.
Jeeva, you told that for that your TCT's values are more like pointing out to a impaired cerebrovascular autoregulation or reserve in patients with low GCS.
Correct, sir.
There is a confounder in that, because severe head injury patient, you might have used muscle relaxant, sedation, and a lot of other drugs, which you probably, how have you excluded those confounders in your results then?
Sir, we did not use traumatic brain injury patients. It was all elective neurosurgical patients that were taken. It was non-trauma patients that we took for the study. And
no, I agree. Because in your group B, probably you have taken patients with low GCS?
Yes, sir. We have taken low GCS patients, but none of these patients were intubated prior to the surgery. Like the TCD values were taken prior to intubating these patients, before giving any sedatives or before giving any neuromuscular blockade. So these values were taken before, prior to surgery itself, before they were given any anesthetic agents. So that confounding factor is not there, sir.
In the exclusion criteria, I just want to ask you, have you excluded any type of patients like retroorbital tumors like that? You have also used ONSD to see.
Yes, ma'am. Yes, ma'am. Retroorbital tumors, sphenoid wing tumors, those patients we did not take in our study, ma'am, because that would confound the ONSD values.
Okay. Any more questions from Dr. Surya?
We'll move on to the next candidate.
Okay.
PGI Chandigarh, and I'm going to be presenting a randomized control trial comparing the effect of 20% mannitol and 3% hypertonic saline on advanced hemodynamic parameters in geriatric patients undergoing neurosurgical procedures. Geriatric patients said to comprise up to 30% of the world's population are vulnerable to adverse perioperative consequences due to the reduced margin of safety and prevalence of multiple comorbidities. The commonly used osmotherapeutic agents are mannitol and hypertonic saline, but their effect on systemic hemodynamics is poorly clarified, especially in the context of an elderly neurosurgical patient. A PubMed search using the following keywords revealed a complete absence of literature in this age group. Therefore, the primary objective was to study the left ventricular output by measuring the left ventricular outflow tract velocity time integral using transesophageal echocardiography post an equiosmolar bolus dose of mannitol and hypertonic saline. The secondary objectives were to compare the brain relaxation score, heart rate, blood pressure, serum electrolytes, total duration of hospital stay, and the neurological outcome between both the groups. We included patients aged above 65 years belonging to ASA class 1, 2, and 3 undergoing craniotomy requiring osmotherapy. Standard anesthesia protocol was followed, guided by bispectral index, and goal-directed fluid therapy protocol was followed, guided by the LVOT VTI assessed using transesophageal echocardiography every 15 minutes up to 90 minutes post the study drug infusion. Appropriate statistical tests were applied, and the results are as follows. The demographic profile was comparable between both the groups. A majority of our patients belong to ASA class 2 and 3 suffering from hypertension and diabetes. 60% of our cases were of aneurysmal subarachnoid hemorrhage, followed by supratentorial space occupying lesion, of which meningioma was the most common. Intergroup comparison of LVOT VTI revealed an increase at 15 minutes in both the groups, followed by a significant decline at 30, 45, and 60 minutes in the mannitol group. It was much better maintained in the hypertonic saline group. Comparison of cardiac output and systolic blood pressure also revealed a significant decline at 45 to 60 minutes in the mannitol group. Comparison of diastolic and mean blood pressure also followed the similar trends, that is a decline starting from 30 lasting up to 90 minutes in the mannitol group, whereas it was better maintained in the hypertonic saline group. The incidence of hypotensive episodes and phenylephrine bolus was also more in the mannitol group. The operating time, blood loss, and the brain relaxation score was comparable between both groups, whereas the urine output was significantly more in the mannitol group at all time points studied. There was a transient increase in sodium and chloride noted at 60 minutes post-infusion of hypertonic saline, which returned to baseline by 24 hours. There was no difference in neurological outcome between both the groups. Now, Chatterjee et al. Demonstrated that the decrease in cardiac output returned to near baseline by 45 minutes in healthy adults, as it was compensated by an increase in systemic vascular resistance. However, in geriatric patients, this decrease may not be compensated due to significant structural changes like decreased elastic recoil and dampened compensated reflexes. The initial hypervolemia followed by the delayed hypovolemia post-mannitol may contribute substantially to adverse cardiopulmonary outcome. Gayatri et al. Did not find any change in left ventricular filling pressures in patients with normal left atrial and ventricular compliance. However, this does not hold true for our geriatric population, where there is prevalence of widened pulse pressure, left ventricular hypertrophy, diastolic dysfunction in the context of autonomic dysregulation, where an increase in left ventricular end diastolic pressure resulting from mannitol may lead to myocardial ischemia, as evidenced by the presence of intraoperative RWMA in 2 patients of mannitol group. The incidence of hypovolemic hypotensive episodes, as defined by LVOT VTI less than 15, and the use of phenylephrine bolus was also more in the mannitol group. Hypertonic saline resulted in much better maintenance of systemic hemodynamics, and the increase in cardiac output was sustained for longer, which may be attributed to its direct inotropic effect or due to reflex activation of the sympathetic activity of the heart. It can be seen here that all the other studies have been carried out in middle-aged adults using pulse contour analysis monitors, which are not accurate in conditions of deranged vascular compliance and hemodynamic instability. Therefore, ours is the first study carried out in the geriatric age group assessing the hemodynamic profile of these agents with the use of a sensitive and accurate monitor like transesophageal echocardiography. Our limitations are the heterogeneous nature of cases and a small sample size, and the varied systemic effects of subarachnoid hemorrhage. We need future studies with a larger sample size and measurement of systemic vascular resistance and cardiac contractility as well. To conclude, the take-home message is that the infusion of mannitol resulted in a significant decrease of cardiac output at 45-60, persisting up to 90 minutes post-mannitol, and hypertonic saline was clearly superior and resulted in a much better maintenance of cardiac output and systemic hemodynamics in the geriatric population. There was no impact on long-term neurological outcome. Thank you.
Thank you, Dr. Ashwini.
Thank you.
So you have use these two agents, how you differentiate in which group you have also patients with comorbidities, what you said?
Yes, ma'am.
Because at higher age group, only age factor is not important.
Yes,
they have many comorbidities. Which comorbidity, in which case you are using it, either hypertension or this thing? How you
Ma'am,
differentiate these two
ma'am,
groups?
it was double blinded. Our exclusion criteria was there was no evidence of end organ damage or significant cardiac dysfunction pre-op. We did a baseline transthoracic echo. We ruled out any systolic dysfunction, any baseline RWMA or any CVD pre-operatively. It was ruled out. RFT was done. Electrolyte balance was noted. Any case of hypo or hypernatremia we didn't include in the study at all. So once all the inclusion and exclusion criteria were met, then we included the patient, and it was the randomization.org, the website. We randomly assigned them. We used a computer generated table and randomly assigned them into two groups.
Is this satisfactory to Dr. Manikandan and Dr. Surya?
How did you blind? You told you were blinded. At what level you have blinded?
So the anesthetist doing the transesophageal echo was blinded. The surgeon assessing the brain relaxation score was blinded, and the hemodynamic parameters were noted by a JR who was also blinded, a resident who was blinded. We gave the study drug using a infusion. So infusion pump was used over 20 minutes, and both the drugs were given through an infusion pump and an unlabeled syringe.
So the person who was doing TE was different from the person
Yes,
who was
sir.
managing anesthesia.
Yes, I was the one who was loading the drug. My guide was doing the experienced anesthetist was doing the transesophageal echocardiography, and the surgeon was also not aware of the group assigned.
So you told two patients had a MI, RWMA was seen.
Yes, sir. RWMA intraop was noted.
Due to what? Was it related to some event or?
No, sir. So we
because we cannot because during the RWMA surgery must have been going on. No?
Yes, sir. We
studied.
Yes, sir. We studied the hemodynamic profile up to 90 minutes of infusion of the study drug. So most of the cases, just craniotomy or dissection was going on. They would not have accessed the tumor or the pathology, the aneurysm during this period. So we ruled out that blood loss or any other intracranial event as the cause of the hemodynamic event. So it was largely either due to the anesthetic agent or the study drug. So that is how we concluded that it might have also multifactorial, but the incidence of RWMA was more in the mannitol group. There were no patients of hypertonic saline group who gave evidence to we could find RWMA drop.
Dr. Surya?
Yeah, have you assessed the acid-base status? Because it's not about only maintaining the hemodynamics, that's also important. But what about systemic oxygenation then? Have you studied that? Any lactate?
Yes, arterial blood gas was done at baseline. We excluded patients with the increased serum lactate, any base deficit, or any acidotic features of acidosis were excluded at baseline. And also we did an ABG at just before the infusion of the study drug and 1 hour later of the study drug and after 24 hours of the study drug. So we found a transient increase in serum sodium and serum chloride in the hypertonic saline group, which returned to normal by 24 hours, but there was no difference in serum lactate or base deficit noted in both the groups.
But anyway, you're opting for an invasive method for calculation of cardiac output. What you have mentioned about pulse contour analysis of different other studies, if you can take the delta stroke volume protocol, then that would have been a better option, because that takes care of all this. Like you have to have a fixed tidal volume, or a heart and lung interaction has to be adequate. All these are well taken care of if you are opting for a delta stroke volume protocol. So transcranial echocardiography is not free from complications as well, because anyway it's an invasive one. So I
have to move to the next candidate. Thank you.
Thank you. Okay.
Hello everyone, I'm Dr. Chayanika Kutum, DRNB third year resident in Neuroanesthesia and Critical Care from GB Pant Institute of Postgraduate Medical Education and Research, GIPMA, New Delhi. My topic is comparison of effects of dexmedetomidine isoflurane combination with dexmedetomidine propofol combination on electrocorticography in patients undergoing epilepsy surgery. Surgery for epilepsy is needed in patients with drug-resistant focal epilepsy if the seizures originate from a region that can be removed with minimal risk of neurologic dysfunction. Epilepsy surgery requires the precise mapping of the area that is responsible for generation of seizures, and hence it is done under electrocorticography or ECOG guidance. ECOG is a direct recording of the electroencephalogram or EEG from the brain surface. The most important concern in the anesthetic management in epilepsy surgery is to avoid or minimize the interference to intra-op ECOGs by the anesthetic drugs that we use. The ideal anesthetic agent for epilepsy should thus be able to minimally affect the ECOG without requiring dose reduction. Thus, in our quest for the ideal anesthetic regime for epilepsy surgery, we studied the effect of dexamethasone isoflurane and dexamethasone propofol combination as anesthesia regimes for ECOG-guided epilepsy surgery. Aim of the study was to assess the effect of dexmedetomidine on ECOG recordings in either isoflurane-based anesthesia or propofol-based anesthesia, to compare the efficacy of the dexamethasone isoflurane regime with dexamethasone propofol regime for maintenance. Objectives. Primary objective was to observe the changes in electrocorticography. First was to see the difference between the ECOG score obtained when isoflurane is administered alone, that is EI, and when combined with dexmedetomidine, that is EDI. Next was to see the difference between the ECOG score obtained when propofol is administered alone, that is EP, and when combined with dexmedetomidine, that is EDP. Last was to compare the ECOG score difference between both the regimes. Secondary objectives were the comparison of heart rate, MAP, recovery pattern, and intra-op awareness in both the groups. Ours was a prospective randomized comparative study conducted from January 2020 to July 2021 in GIPMA with a sample size of 20, 10 in each group. It included patients within the age of 12 to 60 years with intractable epilepsy, requiring epilepsy surgery with ECOG guidance under GA. Exclusion criteria were bradyarrhythmias, hypotension, uncontrolled hypertension, pregnancy, hepatic and renal impairment, cardiac disease, morbid obesity, and known allergy to anesthetic drugs. The methodology: 20 patients were equally randomized into two groups, that is group I and group P. Both the groups were induced with fentanyl, thiopentrone, and daturonium. For maintenance, group I received isoflurane with nitrous O2 mixture, and group P received propofol infusion along with nitrous O2. In both the groups, continuous infusion of atracurium and fentanyl was also given, and BIS was maintained in the range of 40 to 60. Now, prior to the first ECOG recording, BIS was increased slightly to 60 to 70, and a baseline ECOG reading was taken. After that, dexamethasone bolus was given 1 mics per kg over 5 minutes, and the second ECOG reading was taken. Thereafter, BIS was again decreased to 40 to 60, and dexamethasone was continued at the rate of 0.5 mics per kg per minute till the end of the surgery. The primary outcome measured were the ECOG recordings and a difference between them using the Martin grading. The secondary outcome measured were heart rate and MAP measured every minute during dexamethasone infusion and every 15 minutes thereafter till the end of surgery. Next was to measure the time to emergence and time to extubation. Intra-op awareness was assessed by modified Bryce questionnaire. The results: data was analyzed using SPSS 25 with the appropriate statistical test for each variable. A p-value of less than 0.005 was considered significant. Age, gender, weight were comparable. In group I, most patients had MTS followed by focal cortical dysplasia, gliosis, and a case of parieto occipital sclerosis. Group P, most patients were with MTS followed by DNET and a case of focal cortical dysplasia. Now, coming to the electrocorticography findings. Group I, there was a significant increase in ECOG rate after dexmedetomidine bolus administration, whereas in group P, there was no significant change in ECOG rate after dexmed bolus administration. The hemodynamics, heart rate, and MAP were comparable. Recovery pattern time to emergence in group I was longer compared to group P. There was no incidence of intra-op awareness. Regarding adverse events, group I, 2 patients had bradycardia and 2 had hypotension. In group P, only 1 patient had bradycardia. No incidence of intra-op seizures and malposition or migration of electrodes. Discussion. Dexmedetomidine, when added to the propofol, did not affect the ECOGs, but in the isoflurane-based regime, it augmented the ECOG recordings. Similar augmentation of spikes was found in another study by Chaitanya et al. We also found that both dexmed isoflurane and dexmed propofol combination had similar effects on the ECOG, and satisfactory ECOGs were recorded in both the groups. Hemodynamics was also comparable in both regimes. The time to recovery was prolonged in group I, but only the time to emergence as compared to group P. There was no incidence of intraop awareness. Few isolated incidents of adverse events, that is bradycardia and hypotension, were observed, which required no pharmacological intervention. Conclusion: present study demonstrates that dexmedetomidine does not suppress the epileptiform activity when added to either isoflurane or propofol during intraop ECOG. However, augmentation of ECOG was found with the dexmed isoflurane combination, though without any adverse effects. We suggest further studies in larger patient groups to substantiate this finding and, if present, to better ascertain the cause, degree, and side effects of this augmentation. The time to recovery was also increased with the dexmed isoflurane combination, but mostly on the expected lines. Both the groups enabled satisfactory ECOG recordings, provided stable hemodynamics, and did not lead to intraop awareness. Hence, as per our study, both this regime, that is dexmed isoflurane and dexmed propofol combination, can be effectively used for anesthetic maintenance of epilepsy surgery. Thank you.
Questions?
Yes, Dr. Chayanika.
Yes, ma'am.
You mentioned that when dex is added to propofol, it is better than
Yes,
isoflurane.
Yes, ma'am. There was no change in the ECOG gradings.
Gradings and also the patient's
Time to recovery was also lesser in the propofol group. Yes, ma'am.
So, so your message should be like this, no?
Yes, ma'am.
But you said that both can be used. So,
ma'am, in the isoflurane group, the ECOG gradings were augmented after giving dexmedetomidine. However, the augmentation was not harmful. Actually, it was useful in identifying the ECOGs more properly. And also, there was no epileptiform seizure or any incidence of seizure found in the isoflurane group. And also, only the time to emergence was prolonged in isoflurane group. The time to extubation was similar in both the groups, and satisfactory ECOG were obtained in both the groups.
No. When you are saying that the time of emergence is prolonged, then extubation is also prolonged. So your time of emergence, then extubation time is also prolonged.
Yes, ma'am. Yes, ma'am. True, ma'am. Yes.
These two things are there.
Yes, ma'am.
And any hypotension or something, anything doesn't happen, no?
Ma'am, in isoflurane group, yes, ma'am. Only isolated events like 1 or 2 episodes of hypotension and bradycardia were found in 2 patients, which resolved, ma'am, spontaneously. Hypotension resolved with the administration of fluids. There was no need of any intervention of giving any pharmacological agent in any of the patient, ma'am.
Questions from Dr. Monica and then
Yeah, see this bolus dexmed you gave at what time?
Sir, 1 mics per kg over 5 minutes. Sir.
Okay,
yes,
at what period of surgery you gave?
Sir, after the primary ECOG was taken. The first reading, we had taken a reading baseline ECOG recording. Then after that, we had given the dexmed bolus over 5 minutes. Then again, another reading was taken and both the readings were compared, sir.
It was compared blinded by somebody else or?
Yes, sir. The readings, the ECOG recordings were done by the neurophysicist and he was unaware of the anesthetic regime given. So it was double blinded.
Surya.
No questions.
Next candidate, please.
Thank you, sir. Thank you, ma'am.
Greetings, everyone. I am Dhatri Jonna, Junior Resident in the Department of Anesthesia and Intensive Care, PGIMER, Chandigarh. Our study is goal-directed fluid therapy superior to conventional fluid therapy in patients of isolated traumatic brain injury undergoing surgical intervention, a prospective randomized control trial. Traumatic brain injury has 2 components, a primary injury caused by mechanical force and secondary injury caused by factors such as hypotension, hypoxemia, and raised intracranial pressure. The clinical outcome largely depends on these modifiable secondary insults. TBI also has a blood-brain barrier dysfunction, making the brain uniquely sensitive to changes in osmolarity and blood pressure, warranting a unique approach to fluid management. But there is scarcity of literature on the use of goal-directed therapy in patients of TBI undergoing decompressive craniectomy. Our primary outcome was to compare the goal-directed therapy and conventional hemodynamic-based therapy on total intraoperative fluid administered in isolated traumatic brain injury patients undergoing early decompressive craniectomy surgery. Secondary outcomes were to compare the total blood loss and urine output, lactate and hematocrit, GCS at discharge, total days on ventilator, days in ICU, and total length of hospital stay, and Glasgow outcome scale at 3 months post-discharge. Material and methods. A prospective randomized control trial was conducted in the Advanced Trauma Center of PGI from October 2020 to December 2021, after obtaining approval from the Institutional Ethics Committee and taking an informed consent from the patient's relatives. Inclusion criteria were adult patients who underwent decompressive craniectomy for isolated traumatic brain injury within 24 hours of trauma. Exclusion criteria include patients with comorbidities like active coronary artery disease, congestive heart failure, renal dysfunction, and patients with extreme body mass index, blunt trauma abdomen and chest, and spontaneous breathing patients. Basic demographic data, vital parameters, and investigations including GCS and CT scan findings were recorded. Patients were divided into two groups. Group A received goal-directed fluid therapy and Group B received conventional fluid therapy. Anesthesia protocol, patient was taken into the OT and standard ASA monitors were attached. Tidal volume of 8 to 10 ml per kg and a PEEP of 4 centimeter of water with a target of saturation of more than 90% to achieve an EtCO2 of 30 to 35 mm of Hg. Radial artery was cannulated using a 20 gauge arterial cannula. Patient received total intravenous anesthesia with oxygen, fentanyl, infusion propofol, and bolus doses of atracurium. CT lactate and hematocrit measurements were done hourly using ABG analysis. Goal-directed fluid therapy protocol. The patient's hemodynamic parameters were assessed in real time. Our target SVV was less than 12%. If SVV was greater than 12%, fluid was administered. If SVV was less than 12%, cardiac index was looked at. If cardiac index was less than 2.5 liter per minute per meter square, inotropes such as mefentermin or dobutamine infusion was started. If cardiac index was greater than 2.5 liter per minute per meter square, mean arterial pressure was looked at. If MAP was less than 70, vasopressor phenylephrine infusion was started. Fluid administered at the discretion of the anesthesiologist, but colloid and albumin were avoided. Blood and blood products were replaced as per requirement. This is a graph of one of the patients in the goal-directed fluid therapy group. Conventional hemodynamic-based therapy. Arterial line was connected to the anesthesia machine monitor. Crystalloids were infused at a rate of 2 ml per kg per hour with a target MAP of greater than 70. If MAP was less than 70 mm of Hg, bolus of crystalloid was infused to achieve the target level. Inotropes, vasopressors, blood and blood products were replaced according to the anesthesiologist. A sample size of 32 in each group was taken with an alpha of 0.05 and a power of 90%. The statistical analysis was carried out by SPSS version 25. Descriptive statistics were done. Data was tested for normality by Komogolov-Smirnov test. Quantitative variables between the study groups were compared using student t-test for independent samples if normally distributed. Mann-Whitney U-test was used for non-normally distributed quantitative and ordinal data, and categorical data were tested or calculated using chi-square test. A p-value less than 0.05 was considered statistically significant. The demographic data was comparable between both the groups. Primary outcome, the difference between the total intraoperative fluid administered between both the groups was not statistically significant. A difference of 100 ml was observed. Total blood loss, urine output, change in hematocrit, and lactate were also not statistically significant across both the groups, but a trend towards better lactate was seen in the GDT group. As can be seen, delta lactate in GDT was 0.35, whereas in conventional hemodynamic group was 0.06. Vasoactive agents. In goal-directed group, 8 patients received mefentermin and 15 received phenylephrine, whereas in the conventional group, 4 patients received noradrenaline and 12 patients received mefentermin. Total ventilator days, 4-score, ICU days, hospital days, and GCS at discharge were not statistically significant. The Glasgow outcome scale at 3 months post-discharge and the overall mortality between both the groups was also comparable. Conclusion, the difference between the total intraoperative fluid administered between both the groups was not statistically significant. No superiority of GDT over conventional fluid therapy was observed. These are the references. Thank you.
Now questions by Dr. Surya.
Yeah, in your goal-directed fluid therapy, when you are telling goal-directed therapy, if your stroke volumes variation is more than 12%, then how can it be the fluid be given by at the discretion of the anesthesiologist? You have to specify, you have to how much amount of bolus you have to give, how many boluses you have to give to optimize SVV to less than 12% so that you can see the cardiac index. But you cannot just keep on going giving crystalloids because you have told that you are not giving colloids or albumin. So you cannot just say at the discretion of the anesthesiologist in the goal-directed fluid therapy.
No, sir. In conventional, at the discretion of the anesthesiologist, in goal-directed fluid therapy, we gave fluid boluses until the SVV came down to less than 12%. But
so how much fluid, how much boluses of what fluid you have given?
So we give either NS or RL, that is followed at our institute. But how much bolus was given is not specified in my study.
You need to specify. When you are going for a goal-directed, you have to specify how much boluses at what duration, how much time you have to give.
So we assessed the SVV in real time. So until it came down to less than 12% fluid was given. And how much fluid was given
that means, can you give 2 liters of colloid just to optimize SVV?
No,
because
sir.
For few boluses, you have to fix for 3 or 4 boluses. If you are not responding, then what you have to do? You have to specify that. Okay, it's my observation. Ma'am, please, sir, please.
Actually, you missed limitations, you missed a discussion in the part. After results, you straight away went to conclusion. So what is the why your results are not, you mean to say that conventionally anesthetists are very good in managing this? You give a conclusion like that?
Sir, actually, our conclusion was actually studies were conducted in supratental neoplasm patients, in aneurysm patients, but there is no study per se in the subgroup of traumatic brain injury.
No, in your final conclusion, you are telling there is no value of goal-directed fluid therapy.
Yes, sir, there have been a lot of meta-analysis that have come out also that have shown that goal-directed fluid therapy has not shown benefit over conventional fluid therapy.
Your limitations were what?
My limitations is a smaller sample size. A larger sample size would be more preferable in these patients. And as Sir has said, specifying how much bolus needs to be given is also important in these patients.
That's what. Okay. Thank you. Madam.
Thank you.
Not at all satisfied what you said about the fluid therapy.
We'll move on to the next candidate.
You have to monitor. You have to monitor also you are going giving that fluid chest monitoring is also there. So you have included the aneurysm cases. So you have to be very cautious about that, no?
Ma'am, I have not included aneurysm patients, ma'am. I have taken only traumatic brain injury patients.
Oh, acha. Only traumatic brain.
Yes.
Then it is also very important to think that what is the status of the brain swelling and all these things.
Yes, ma'am.
Next candidate, please.
Good evening, myself Dr. Praveen, working as an associate consultant in the Department of Neuroanesthesia and Neurocritical Care in MGM Healthcare, Chennai. Today I'm going to talk about an interesting case of ruptured aneurysmal subarachnoid hemorrhage in an adolescent with Alport syndrome. Ruptured aneurysmal subarachnoid hemorrhage is uncommon in pediatrics and adolescent age group. Collagenopathies, including type 3 and type 4 collagen, is implicated in the pathogenesis of subarachnoid hemorrhage. Alport syndrome is a very rare genetic disorder which is due to an imperfect synthesis of type 4 collagen. It can cause glomerulonephritis, eye-tone sensorineural deafness, and ocular abnormalities. My case is a 17-year-old adolescent male who presented with history of headache and decreased responsiveness. He is a known case of end-stage renal failure due to Alport syndrome, biopsy proven, who underwent a deceased donor renal transplant 3 years ago. He also has bilateral bipolar cataract where PCIOL was implanted. Bilateral sensorineural deafness is on hearing aids. His presenting GCS was E1, B1, M2 with pupils to MM bilaterally strategically reacting to right. His modified Hunt and his score was grade 5 and his WFNS score was grade 5. He was on diabetes and on oral hypoglycemic agents. He was on immunosuppressants since he was a renal transplant recipient. He was on tacrolimus, mycophenolate mofetil, and Visolon. His initial CT scan revealed diffuse SAH with intraventricular hemorrhage and hydrocephalus. His CT angio was negative for any aneurysms of AVMs. His modified Fisher score was grade 4. CT test was done where Corad's 2 and its right lobe aspiration changes were present. He underwent emergency right frontal EVD for his hydrocephalus. Post-procedure, his ZCS improved to E3, VT, M5, and his pupils were 2 mm bilaterally sluggishly reacting to light. His initial TEG were within normal limits. The next day, he underwent digital subtraction angiography under GA. It showed bilateral superior cerebellar aneurysm, which is a fusiform aneurysm. Since it is fusiform, therapeutic options were discussed and we proceeded with conservative management. He was sedated and ventilated. During DSC, it showed early vasospasm changes. So he was on hypertensive therapy and nimodipine 30 mg 4th hourly. On day 3 of ICTUS, there was a neurological deterioration. His GCS deteriorated to E1, VT, M1. There was anisocoria. Pupils were left as more than right. He immediately urgent CT scan was done and showed posterior fossa fullness. And also there was that right frontal EVD was not draining, so he underwent emergency posterior fossa decompressive craniectomy with C1 arch excision, and left parietal EVD insertion was done. This is the immediate post-op CT imaging showing the posterior decompression craniectomy and the left parietal EVD. Since there wasn't vasospasm features in DSA, we did serial TCDs for follow-up. As TCDs were in the right MC and left MC was seen, and the mean velocities were within 73, 74, within normal limits. Post-op course, immediately post decompressive craniectomy, his GCS was E4, VT, M4 status. During the course in ICU, he went succumbed to sepsis and ARDS. He was started on higher antibiotics and antifungals. This is the chest X-ray of his lungs, showed bilateral ARDS. Fiber optic bronchoscopy and bronchial lavage was done, and appropriate culture sensitive antibiotics was started. PDT was done, and weaning trials were given. His discharging GCS was E2, VT, M4. He was discharged to a local hospital for further neurology rehabilitation. Coming to discussion, subarachnoid hemorrhage is mainly due to a large congenital defects in the media of the cerebral vessels and hemodynamic stress in collagenopathies. Special interest in pediatrics and adolescent age groups include it has more preponderance for males. There is a predilection for posterior circulation and carotid bifurcation, and there is a tendency to reach larger sizes, and it is associated with polycystic kidney disease and coagulation of aorta. Connective tissue disorders including Ehlers-Danlos syndrome, Marfan syndrome, osteogenesis imperfecta, pseudoxanthoma elastica, neurofibromatosis type 1. These are due to type 3 collagenopathies can result in increased vascular fragility. Type 4 collagenopathies include Alport syndrome. Type 4 collagen is the main constituent of basement membrane. It plays a fundamental role in the vessel wall integrity. Coming to Alport syndrome, it is due to mutations in the alpha subunit. It can be X-linked or autosomal recessive, autosomal dominant. Or X-linked is due to alpha 5 chain mutation, and autosomal recessive and autosomal dominant can be due to alpha 3 or alpha 4 chains. We postulate that genetic defect leading to abnormality in the type 4 collagen molecules may have resulted in the formation of aneurysm in our patient. Conclusion: it may be reasonable and advisable to look for collagenopathies in young patients with vascular aneurysms. MRA or CT angio may be useful as a screening modalities for such high-risk patients. Surgical and autopsy specimens of vascular aneurysms from patients with known collagenopathy is needed to demonstrate more unambiguous molecular and genetic correlation of vascular aneurysms and collagen abnormalities. Clinical and epidemiological studies are warranted to establish stronger and well-defined association between prevalence of intracranial aneurysms in patients with collagen synthesis dysfunctions. Thank you. These are my references. Thank you.
Respected judges, you can ask him
Yeah.
questions, but since it was a case report, it may not be considered in this category. But you can ask him questions, sir.
Surya, we can ask because Praveen was our ex-student also. Next.
What is so specific? What is not known to us? You have told. Like this is a collagenopathy. They have high predilection for larger aneurysms. You encountered such a case which has arguably had a prolonged post-operative course,
Yes,
and you managed well. That's it. So my question is, what is so unique about your?
No, just this collagenopathy is aneurysms may occur in this collagenopathy patients in order to report it.
Okay. Anyway.
You have investigated him for the collagenopathy, whether it is rheumatoid or whatever the.
Renal biopsy was positive for Alport syndrome.
Okay.
Previously for renal transplantation.
And vascular studies in the intracranial vascular studies, have you done anything?
No, not done.
Okay, we'll move on to the next candidate.
Thank you.
Afternoon. I'm Dr. Prachi Sharma, and I'm presenting the results of a prospective observational pilot study titled Performance of Analgesia Nociception Index as a Monitor of Nociception Anti-Nociception Balance in the Pediatric Neurosurgical Population. So ANI measures the nociception anti-nociception balance effectively in adult neurosurgeries, but its reliability in pediatric neurosurgery is unknown. We aim to evaluate the performance of ANI in the pediatric neurosurgical population undergoing elective craniotomies for intracranial lesions, and our primary objective was to validate ANI for prediction of acute post-op pain in this population. The secondary objectives included to observe the changes in the values of ANI and surgical plethysmographic index or SPI before and after opioid administration, and to correlate the peroperative changes in ANI values with hemodynamic variables, that is heart rate, mean arterial pressure, and SPI at various time points of noxious stimulation. Study was conducted over 6 months period between December 2019 and May 2020, and children between 2 to 12 years of age were included. Children who were not extubated and shifted for elective ventilation, those who received alpha-2 agonist, and those who were ASA physical status 3 and above were excluded. In the OR, after obtaining the baseline values of monitors of interest, a standardized protocol was used for induction and maintenance of anesthesia in all cases. Intraop fentanyl boluses were given as deemed appropriate by the in-charge anesthesiologist, and they were not guided by the ANI values. Intraoperative monitoring included hemodynamics, heart rate, blood pressure. Besides these, SPI, instantaneous and mean ANI, and entropy values were noted. In the PACU, pain was assessed using the revised Flack scale, and simultaneously heart rate, MAP, and ANI values were measured. Data collection time points intraoperatively included points of noxious stimulation like intubation, skull pin insertion, skin incision, craniotomy, dural closure, skin closure. For opioid administration, one value was taken prior to opioid administration, and after fentanyl administration, values were obtained every minute for the next 5 minutes and then at the 10th minute. In the PACU, once the modified OASS score reached 4, the first value was taken, and after that, values were taken at 10 minutes interval till discharge from PACU. Data was analyzed using the R software, and linear mixed effect model was used for observing influence of time points on the variables of interest. For observing correlations, repeated measures correlation was used. A p-value of less than 0.05 was used as the level of statistical significance. Out of the 18 patients that we included, 4 had to be excluded due to deviation from the study protocol. Out of the 14 patients analyzed, power achieved was 99%. The average age was 7 ± 3 years. We had 10 male and 4 female patients, and supratentorial to posterior fossa lesion ratio was 1:1. Coming to results for the intraoperative data, any noxious stimulus that increased the heart rate and the mean arterial pressure led to a reduction in the instantaneous ANI values, highlighting a negative correlation between these variables. The SPI shown by the green line also changed, but the change was not very consistent. For the scatter plot of values of ANI-I and ANI-M intraoperatively with different variables, we can see that the association was not very strong. However, even though the association was weak, it was consistent and statistically significant. For the trend of change of values in ANI after fentanyl administration, we observed that for patients who started at lower values of ANI before fentanyl, there was a much steeper increase in the values of ANI compared to patients who started at higher values of ANI before opioid administration. Such trend of change was not observed for SPI values. As we can see, most of the patients, they stayed parallel throughout. So when we looked at the interaction between the time of opioid administration and the presence or absence of nociception anti-nociception balance, we found that for ANI, there was statistical significance at time point 3 onwards. Heart rate and MAP also sequentially reduced after opioid administration and reached statistical significance at 3 points. But there was no statistical significance between time of opioid administration and SPI. For post-operative data, which was our primary objective, the scatter plot of correlation between values of ANI-I and ANI-M with hemodynamic variables shows a strong negative linear association. And this negative correlation was statistically significant, highlighting consistency between ANI and the hemodynamic variables. When we assess the predictive values for acute post-operative pain, the AUC was strongest for instantaneous and mean values, followed by heart rate, but for MAP, it was not strong. Thus, to conclude, in the pediatric neurosurgical patients undergoing elective craniotomies, ANI can be used as an objective measure of acute post-op pain with as much reliability as hemodynamic variables. For intraoperative period, ANI measures the response to noxious stimulus similar to SPI and hemodynamic variables. However, the correlation between these variables in the intraoperative period was not strong, which highlights that there are many factors other than pain in the intraop period which confound the relationship between these variables. For opioid administration, ANI values were shown to reflect nociception anti-nociception balance better than SPI in this population. Thank you.
Questions?
Thank you, Prachi, for that very good study you have done. And,
thank you, ma'am.
Questions for Prachi?
Yeah, Dr. Prachi, this I want to, I had one doubt. The ANI you measured in the post-op also?
Yes, sir.
How did the child allow, kids allow you to keep all those?
So we actually measured ANI only once the modified observer's assessment sedation alertness scale was more than 4 or 5. So at that time, the monitor, that was the ECG that we monitor, those stickers were kept and it is a standalone monitor. So it was shifted along with the patient in the PACU. So in this period, only when the values were taken, only when the modified observer's assessment alertness scale was 4 or 5. So we had a total of 92 values at different time points from these 14 patients that we could assess and evaluate.
Do you think there is any confounding, neutral confounding? What are the limitations of your study?
So the main limitations of the study was, besides the small sample size, we did not differentially assess infratentorial and supratentorial lesions. First of all, we included all the patients so that there was a 1:1 ratio for supratentorial and infratentorial lesions. Secondly, there are a number of other factors that may affect the values of ANI, which we do not take into consideration, like which hemodynamic disturbances can occur because of causes not just pain, because of other causes including acute blood loss in the intraoperative period, or because of medications that affect the autonomic nervous system activity. So this was not taken into consideration because this was not in the objectives of our study. However, in studies which have been conducted in our institute only, it has been shown that ANI is actually effective even in periods of acute blood loss, and in meningioma studies it has been done in adults, though not in pediatric patients. They have shown that ANI is indicative of pain even when the heart rate and the MAP change because of significant blood loss of more than 1 liter on an average. So this has been shown. So maybe this is one of the reasons why for intraoperative data, we did not have a very good correlation between ANI with heart rate and MAP and SPI values. The correlation was there, it was statistically significant, but the strength of the correlation was not very good. So this could be one of the factors. We only excluded patients who were given alpha-2 agonists. So noradrenaline or mefentermine, when they were administered, those things were not taken into consideration. Another limitation was for looking at the change with opioid administration. We defined patients as presence or absence of nociception or anti-nociception based on a cutoff of 50. However, this cutoff of 50 has not been proven in pediatric patients, because there are not studies in pediatric patients that have looked at what is the value which will indicate nociception, anti-nociception. So maybe the future scope of the study is that we can use ANI guided opioid administration and look at PACU pain scores, or look at the emergence agitation in these patients to know the adequacy of analgesia, or we can use see the opioid sparing effect of ANI. In that case, maybe we'll be able to derive a cutoff.
So all these patients in the post-op are having good GCS 15? Or,
Yes, sir. Only patients who had good GCS were included.
Post-op. No, what I mean to say in post-op.
In the post-op period only, sir, because patients who were not extubated, they were actually a part of the exclusion criteria. Those who were shifted directly to the ICU who were not extubated because of any reason, or who were shifted on TPs also, they were excluded. So GCS was standardized for these patients.
Also the type of the lesion, like in meningioma. So these patients may have, they are prone to have pain.
Yes, ma'am.
In cases of any. So it is also a factor that what type of lesion was there and what.
Ma'am, we had a 1:1 ratio of supratentorial and infratentorial lesions. So the pathologies were gliomas were there, or bitofrontal lesions were there, choroid plexus lesions were there, and medulloblastomas, pilocytic astrocytomas were there, which is more common in pediatric age group. But the thing is, which I also mentioned as a limitation, we did not differentially assess these pathologies, and considering pain is more prominent in infratentorial pathologies, we do not know how that will affect our study outcome. Because the sample size was so small, the study was conducted during peak
You
COVID
have said
period.
that it is a pilot study. So,
yes, ma'am.
Next candidate, please.
Thank you.
Good evening. Today I am here to present the topic Impact of Anesthetic Induction with Etomidate, Thiopentrone and Propofol on regional cerebral oxygenation. The aim of this study was to see the effect of these three agents on cerebral oxygenation in patients undergoing emergency surgery for brain trauma. Secondary objectives were to evaluate the effect on hemodynamic parameters, to observe the effect on serum cortisol levels, effect on hematoma volume, and to observe the prognosis after 30 days. Inclusion criteria comprised of adults 18 years and above undergoing emergency surgery for brain trauma, and the exclusion criteria helped in laying down the study cohort. The baseline demographics were noted down and NIRS sensors were placed on forehead. A standard induction protocol was followed, and thereafter an anesthetic agent of anesthesiologist's choice was administered. Rocuronium was given and modified RSI protocol was followed for intubation. Maintenance of anesthesia was done with sevoflurane with MAC kept between 0.5 to 1% in air oxygen mixture, and three groups were formed. The observed parameters being recorded at preoperative, post-pre-oxygenation, post-induction, post-intubation, and pre- and post-extubation. The study was funded by ICMR research grant, and the statistical analysis was done by R software. The finalized cohort of 115 patients was analyzed, and 50 patients were allocated to the etomidate group, 33 to propofol group, and 32 to thiopentrone group. The demographic parameters showed no statistical variation across the three study groups. On analyzing the primary objective of trend of ipsilateral RSO2, we observed a significant increase at first minute of induction in etomidate and thiopentrone groups. Thereafter, increase also occurred at second minute of intubation in all the three groups. A similar pattern was observed on the contralateral side in induction as well as at intubation time points. On analyzing the secondary objectives, we found no significant decrease in serum cortisol levels with the use of etomidate. The mean arterial pressure only shows a decrease at second minute of induction in the etomidate group in comparison to thiopentrone and propofol, where the decrease starts at first minute of induction, and was also seen till fourth minute of intubation in thiopentrone group and till second minute of intubation in propofol group. Heart rate has relatively remained stable across the induction as well as the intubation time points. Looking on to the effect of GCS, it has improved significantly at discharge in all the three groups. Coming on to the correlation matrix, the blood pressure, heart rate, and end-tidal carbon dioxide show a negative correlation with RSO2, and the same trend has been observed on the contralateral side also. Lavelle et al. Conducted a study on 36 patients using spectrophotometer and found RSO2 to increase in thiopentrone and propofol group. We have found it to increase in all the three groups. Kusmenkov et al. Conducted a study on 49 patients and found a decreasing trend of cortisol values in the brain trauma patients. Whereas Bansalla conducted a study on 277 patients and found values less than 276 nanomoles per liter to be associated with high likelihood of mortality. Ugyur et al. Found that fall in blood pressure occurs with the use of propofol, whereas Karki et al. Found no change in blood pressure with the use of etomidate. Sorensen et al. Found a positive correlation between end-tidal carbon dioxide and cerebral oxygenation. We have found a negative correlation between the two owing to the intact cerebral autoregulation in our patients. Schober et al. Found it 70% false positive results. Therefore, he could not correlate hematoma volume with RSO2 values. And we also could not find a correlation between the two. Main limitation of our study was that it was not randomized. Then we conclude that all three agents increase RSCO2 and hemodynamic fluctuations were least observed in the etomidate group. Therefore, etomidate in a dose of 0.3 milligrams per kg IV can be safely used as a single bolus induction agent in addition to thiopentrone and propofol in brain trauma patients. Thank you.
Questions, please.
What is, yes, Dr. Sharma? Thank you. You
Good
said
evening.
that in addition to propofol and thiopentrone.
Ma'am, propofol and thiopentrone have already been proven as good agents for a traumatic brain injury. So etomidate, the concern was whether this is going to decrease the serum cortisol values because the same has been shown in non-traumatic brain injuries.
What
So
you
this
said that, the outcome scale was good, and at the time of discharge, patient was also having a good GCS.
Yes,
So,
ma'am.
what was the duration of stay?
Ma'am, the duration of stay in 50 to 60% of the patients was between 4 to 7 days, and the remaining patients, the duration was around 2 weeks. And some 5% of the patients, the duration of stay extended to 1 month also, ma'am, in ICU.
So there are many factors which
Yes,
will
ma'am.
determine the GCS at the time of discharge then.
Yes, ma'am.
So,
Did you notice any pain on injections or any abnormal movements with the etomidate?
No, sir. Myoclonus did not occur, and the protocol of anesthesia involved giving fentanyl also prior to giving the anesthetic agent. So we did not observe any pain in the traumatic brain injury patient on administration of
Normally,
anesthetic
yeah,
agent.
in TBI patient, we generally tend to give a RSI, no?
Yes, a modified RSI protocol was followed.
So, do you think why etomidate is not very famous? Is it related to the RSI because it takes time to act?
Sir, the main reason for not famous, I presume, is that it decreases the cortisol values in the elective cases. So, in
Actually, you have clearly told in your study, so BPs tend to fall very early in propofol and thiopentrone groups. They act much faster compared to the etomidate. They take little longer time actually. When you want to try for a RSI, modified RSI in traumatic brain injury. So that was one of the major issues when you give etomidate. It takes a little longer time than that. And the second thing is we don't know much about the intracranial pressure in the etomidate. Okay, so we are not. It is not as safe as you think because what happened to the CSF in CSF dynamics? Is it affect etomidate?
So we were not measuring ICP in the
I'm telling you, in the
brain trauma
pharmacology, you
patient.
must have read, no? It can
Yes, sir.
increase,
It will.
it can increase the ICP also, no?
Yes, sir.
Yeah, that is some of
But
the
we were
concerns
not
are there in traumatic brain injury. That's why we were so many age-old, drug, but still it is not very popular. Because, of course, if patient is unstable, hypotensive, definitely it has got a role. But routine practice, I don't know whether it can really give advice on it. We can use it.
again, only the cortisol level is not the marker of the patient's intracranial homeostasis.
Okay, ma'am.
If there are no more questions.
Dr. Surya, any
okay, yeah, please. So if there are no more questions, we have come to the end of this session of free paper presentation. Thank you, judges. Thank you, candidates. So we are closing the session right now. And this is the last session of the day 2 of our conference. Good night, everybody. and hope to see you again tomorrow at 8.
Good night and all the best for all the residents. Everybody present.
Dr. Surya?
What about this Dr. Pooja Chapegadikar?
No, they probably, I mean, they had some issues, so they did not attend.
No, Madhavi Desai also is
No.
absent?
Yeah, she's absent. Probably, actually, the COVID is a big issue, so probably a lot of people are affected by COVID and they're not in a position to present.
Thank you. Thank you so
Thank
much.
Thank you all. Thank you very much.
Thank you very much.
Thank you. Bye. Good night.
Good night. Good night.
Good night.
Good night, ma'am.